Dr. Buttar is here. Thank you very much taking our invitation. And I just start up explaining about hypoxia and Kaqun water and their relation. And we would like to know about your opinion on hypoxia, and maybe you can give us more information about this, because all the people here, they know about hypoxia is not something very good, but we need more secure information from you. Thank you very much, and really proud you are here in our conference at the moment.
Well, thank you, Dr. Lyons. I appreciate the invitation, and I apologize for the background that's behind me right now. It's the only decent background that I had. I'm traveling right now, so it was a little bit difficult to make sure that I had an appropriate, it was either this or a kitchen in the background. So I figured that I'd pick this as a background. You know, the discussion about the importance of oxygen is not really a discussion that seems to be, like, if you talk to a medical group about oxygen, like, everybody looks at each other like, well, of course we know it's important. You know, without oxygen, we're dead. You can go without food for 80, 90 days. You can go without water for 3 or 4 days, but without oxygen, you've got literally a couple of minutes, you know, 3, 4 minutes. Within 5 minutes, the vast majority of people that are not getting sufficient oxygen, they would be dead. So what's the point of talking about oxygen? Everybody knows how important it is. Everybody knows how essential it is to life. Well, there are a couple of things that I want to kind of mention today. And the first is that oxygen is a double-edged sword, and we need oxygen to survive, but it's also oxygen that is responsible for the oxidative reaction or the oxidative injury. In chemistry, we call it the reduction reaction. It's oxygen that's responsible for that. Without oxygen, you don't have any aging. In fact, if you can remove oxygen, and by the way, just so everybody's on the same sheet of music, the reduction reaction chemistry, or oxidative injury, which we typically refer to it from the biological sense, is nothing more than the rusting process. And so oxygen is responsible for that rusting process. And it actually causes an acceleration of that rusting process. So we have substances that are oxidative, but then when in the presence of higher levels of oxygen, they'll actually become more destructive and causes more problems. But if you remove oxygen from the environment, an individual can be preserved the same way. I ask women in conferences all the time, if I could guarantee you that I could keep you looking the exact same way you look today, and you never age a minute for the next 10,000 years, how many people would be interested in that? And of course, everybody raises their hand. And then I tell them, well, there's only one problem. I have to kill you instantly right now, meaning that you have to put the person in an environment and evacuate all the oxygen out. And if it's sealed off and there's no oxygen, there won't be any deterioration. The tissue would look exactly the same. So oxygen is a double-edged sword. We need it to survive, and yet it's the thing that's responsible for aging. So the key comes down to using oxygen in a way that is able to help us without hurting us. So reducing the amount of oxidative injury with as maximum of utilization of oxygen as we are meant to be using it, that's really what the key balance is. Now, when we start to talk about the role of oxygen in medicine and health, I don't know how many lay people, non-medical people know this, but when you start to look at things such as the life support courses, the trauma support courses, the courses that are taught to doctors to how to deal with trauma. So there are 3 specific courses. There's advanced trauma life support, which is the course that's taught to the American College of Surgeons for doctors how to deal with penetrating trauma and blunt trauma. Then you've got the ACLS course, Advanced Cardiac Life Support, which is through the American Heart Association. And then you've got PALS, which is a Pediatric Advanced Life Support, which is through the American College of Pediatrics, and actually the American Heart Association as well. So all three of these courses are courses for doctors to take in how to deal with traumatic situations, whether it's pediatrics, whether it's cardiac, or whether it's trauma. And the first line of drug, for example, in ACLS this is a test question. So if there's a doctor or nurse who hasn't taken the ACLS course, remember this test question will come up. What is the first line of therapeutic? So first, what is a drug of choice in resuscitating a patient that may be having a heart attack in ACLS? And the first choice of drug is oxygen. So when we start to have a deterioration of oxygen or inability of our body to get adequate oxygen, it can start to lead to certain problems. And those problems will manifest in various ways. So there are two specific types of, I guess, definitions, you could call it. There's two definitions when a person starts to have inadequate oxygenation. One is called hypoxia, and some of you, I'm sure most of you know what hypoxia is. And then there's hypoxemia, and that's something that maybe people think is synonymous, but in actuality, it is not synonymous. So hypoxia versus hypoxemia are different. So let's talk about what the difference is in those two, all right? So when we start talking about, and I apologize, I should have had some slides, and I don't have any slides here right now. I actually did have some slides, but because of the internet problem, I wasn't able to access those and amend them. But when we start talking about hypoxia is something that is when we have a decrease in oxygen saturation. And that's very easy to measure with something like a pulse oximeter. And basically what a pulse oximeter does is you put it at the tip of your finger, and it's picking up the level of oxygen saturation in the blood. So that's usually how hypoxia is actually measured. It's a very, very common thing that's done in hospitals. We use it in our clinic, and pretty much for a couple $100, you can have a device that you can put on a person's fingertip, and it will give you the measurement of oxygen saturation, which is an indirect measurement of how well the lungs are working, how well your blood is going through the lungs and getting rid of the carbon dioxide, picking up the oxygen, and being able to carry that oxygen to the end cells, which is what the purpose of hemoglobin in the red blood cells is to carry oxygen. So that's measured using pulse oximetry, oxygen saturation of the blood. And that's, again, something that if a person's levels are dropping down, if they're down to say 95, 93%, 90%, you would say that this person is hypoxic. Okay, if it's over 98, 99%, that's considered to be normal. Now, hypoxemia is a different thing. Hypoxemia is actually a decrease in the partial pressure of oxygen in blood or tissue. Typically, when you're thinking of blood, you're just thinking of hypoxia, which is measured, as I said, through pulse oximetry. But hypoxemia is a decrease in the partial pressure. There's a difference between a decrease in oxygen saturation and a decrease in partial pressure. When you're looking at an individual, when you're looking at an individual and just eyeballing them, a clinical evaluation when somebody's sitting in an exam room and you're just talking with them, if they're hypoxic, you may be able to tell, you may not be able to tell, meaning there's not clinically evident, observable phenomena. You'll have to do pulse oximetry or some, arterial blood gases or something to see how well they're oxygenating. Whereas with hypoxemia, you can see the difference. This is where the person's going to be a little dizzy. They may look a little ashen. They get a little gray. They'll be, they'll be cyanotic. The peripheries, the digits may be blue or purple. That's hypoxemia. All right. So hypoxemia is very, very evident to an observer, whereas hypoxia, they could have it, they could not have it. It doesn't necessarily mean you can observe it. All right, now what type of conditions are we going to be seeing this type of situation? Where do we see hypoxia as far as when we're dealing with clinical medicine? What type of medical conditions would we see this with? Well, pretty much anything to do with, when you start dealing with heart disease, anything to do with heart disease is, if you can increase the oxygenation in that individual, you're going to at least help them. You may not necessarily get rid of their symptoms if they're, say, in fibrillation, or they have some type of arrhythmia, but increasing their oxygen will help them to be symptomatically better, to give symptomatic relief. May not deal with the underlying issue completely, but it'll give them symptomatic relief at least, because it could be a mineral deficiency, it could be an electrical disruption, whatever the case is going on. Cancer, for example, cancer is an obligate anaerobic metabolizer. Cancer needs an oxygen-free environment. If you can increase oxygenation in the body, cancer is going to have a very difficult time surviving. In fact, that's the reason that we do hyperbaric oxygen therapy in our clinic, because it's you're using oxygen as a main form of treatment to increase the level of oxygenation in the blood in the body, and it's actually not in the blood, in the body, but there's obviously residual spillover into the whole system, so you have it in tissue, and that's the most common way of trying to increase partial pressure of tissue is through hyperbaric oxygen therapy. Of course, stroke, same thing. Stroke is going to be whether it's a TIA, or transient ischemic attack, or a RIND, which is a reversible ischemic neurological deficit, or a full-blown CVS, cerebral vascular accident, which is the definition between those three is how long the symptoms last. If it lasts within just the first 24 hours, it's considered a TIA. From 24 hours till 2 weeks, and then resolves by 2 weeks, it's considered a RIND. And if it's greater than 2 weeks, then it's considered a full-blown CVA or a stroke. So in stroke situations, you're going to have a symptomatic improvement relief with increasing in oxygenation of the tissue. One of the things that we've seen is COPD, chronic obstructive pulmonary disease, where we can really make a radical difference in a person if we can increase their tissue oxygenation. Obviously, things like asthma, diabetes, actually comes down to any chronic disease is going to be impacted if you can increase the oxygen utilization in the body. And when you start to talk about chronic disease, the common characteristics of most common diseases is inflammation. So if you can increase oxygenation and the tissue perfusion level by increasing the partial pressure of oxygen in the tissue, you're going to actually have a decrease in inflammation, and you're going to have a decrease in symptomology as a result of that decrease in inflammation. And any type of ischemic injury anywhere, right? So not just heart or stroke, but if you have a crushing injury, anything that would cause ischemia. Ischemia is basically lack of perfusion. So essentially any kind of chronic disease is going to be impacted if you can increase oxygen saturation in the tissues as measured by increasing partial pressure. So my my presentation, I was asked to talk about the importance of oxygen in the body and the role of oxygen in the body. And so for all of my experience I've been a doctor now 29 years, all the way from going one extreme, which is just dealing with the patient, say in a non-emergent family practice, routine visit standpoint, all the way to the opposite extreme where somebody has sustained multiple penetrating traumas, shot twice and stabbed once, whatever, they're bleeding out. In that whole gamut, you've got the importance of oxygen, and without that oxygen, the person's obviously not going to be there. In our clinic, we deal with patients with cancer from all over the world. We have patients now from 94 different countries. And as of December 2019, exactly a year ago, we haven't looked at the data completely for this year, but as of December 2019, we have 14 stage 4 cancer patients, and stage 4 is considered terminal, end stage, nothing left to do. They've failed all the conventional therapies. We had, usually the prognosis is anywhere from 3 months to, if you're lucky, up to a year. We had, as of December 2019, we had 14 stage 4 cancer patients that were 15 years out from our treatment. So they had outlived their life expectancy after our treatment, after what we did for them, at least by 14 years, possibly 14 and a half more, maybe more than that, because depending on how much time that they'd been supposedly given. One of those patients is more than 20 years out from his treatment. So one of my mainstays of helping these people has been using ways of increasing oxygenation in their systems. And primarily in the past, we had used the hyperbaric aspect. Basically, I have been working on some things, and Dr. Lyons and I came together because one of the commonalities was because of a method to increase oxygenation in the water, using water as a utilization tool. And there's a version that we have that we've been using now, and Dr. Lyons has been very helpful in helping us with establishing some of the groundwork for the research to be able to substantiate the ability to actually have a sustained level of increase in tissue perfusion of oxygen. And remember, there's a difference between tissue perfusion of oxygen and blood saturation of oxygen. So tissue saturation of oxygen and blood. So when you're looking at blood saturation, that's something that is easily measured by a pulse oximeter, but tissue perfusion or tissue oxygenation levels, it's a different thing. You can't measure it as easily. And that's where you start getting into the hypoxia and hypoxemia. And a lot of people use the term hypoxia and hypoxemia interchangeably, and that's fine. It's more than semantics, but in typical conversation, it's not a big deal. But when you're talking from a specific definition, there is a significant difference between what hypoxia is and hypoxemia is. The bottom line is if you can increase oxygenation in either case, you're going to have a significant long-term benefit to the patient from a measurable, not subjective, but an objectively measurable improvement in the patient's outcome. And I can't think of a single disease. If you said diabetes, yes, it has an impact in diabetes. Arthritis, yes, it has an impact in arthritis. Even with athletes, okay, if you can increase their utilization of oxygen, you're going to have a better performing athlete. You're going to have basically an improvement from a functional standpoint in anybody if you can improve the utilization of the utilization of oxygen in an appropriate manner. And when I say in an appropriate manner, what am I talking about? I'm talking about so that oxygen is being utilized for a purpose and in a manner that increases performance and helps the person achieve the outcome, which is better perfusion of the tissue, i.e. higher partial pressure of tissue, without crossing over into the higher oxidative stress and causing acceleration of that oxidative injury, which is responsible for more rapid aging, et cetera, et cetera. So that's why I say it's a double-edged sword, and it's almost like walking a fence line, right? You can increase oxygen rapidly in a person, but that's going to cause rapid oxidative injury, and we don't want to do that. And so to give you an example, if you rapidly increase oxidative injury in a cancer patient, they're going to die faster, quicker, without any doubt. But if you can increase utilization of oxygen in a person, appropriate utilization of oxygen in a person with cancer, you're going to actually prolong their life significantly.
Dr. Buttar,
yes.
What would you say about ozone therapy?
So we do a lot of ozone therapy in our clinic, ozone autohemotherapy, and we actually combine it with UVBI, which is ultraviolet blood irradiation. And so we basically withdraw so much blood out of the body. We put ozone in the blood, and then we take that blood and we take it through a specific light spectrum, an ultraviolet light spectrum, and then we reinfuse that ozonated blood that's been exposed to the UV light back into the body. And we do that for many conditions, such as infectious type processes or organic pollutant processes. That's one reason I've never gotten excited about the current COVID nonsense, because to me it's no different than any other type of flu or anything else like that. So let's talk a little bit about ozone first, and then we'll come back to the COVID if that's okay. The utilization of ozone, it's not new. It's been used for many, many years, probably close to 70 years. And a lot of the literature was actually German literature and Eastern European literature, where they were using ozonation and ozonated components, like they'd actually ozonate water. Ozone has actually been used as a sterilizing technique for a long time, but ozone is O3, okay? So the problem is that when you're breathing in oxygen, it's typically O2, but ozone is O3. Ozone is highly, highly oxidative, very potentially damaging to an individual, to anything. If you actually take ozone and you take one of your latex glove, you got it on, and you just run that ozone without touching it, okay? Let's say it's about 2 inches away from the latex glove. So it's just the ozone, it's nothing touching it. It will cut that latex as if it's a knife without being an inch away. So ozone is very destructive. People that live out in California, for example, they're familiar with the ozone alerts, right? The quality of air is very poor. Ozone alert is red or orange or whatever, and people stay inside their homes because they can't breathe in that ozone. Well, then if that's the case, why are we ozonating blood? What's the purpose of ozonating blood? Why, if this is so destructive and it's so bad and it's so oxidative and it's causing such severe problems, why would you use it for to treat blood and to put it back in the person? Well, it's a very good question. Of course, this is a rhetorical question, but I'm going to give you the answer. That's why I'm saying it's a good question. I like to set up a good question and say that's a good question so I can answer, because it's a good answer that I have. So let me explain that to you. It's like telling a joke, but you make sure that the audience already knows what the punchline is so that they all are prepared for the joke. So anyway, the point is that the oxygen, when you see the oxygen molecules when it's given in ozone, it's in this detrimental format that's highly oxidative, right? So when we talked about earlier on in the presentation, when I talked about the oxidative nature of where oxidation is the bad component of oxygen, but life or sustainability is a good part about oxygen, and we can't live without oxygen. But if we didn't have oxygen, if we didn't have oxygen, we'd be dead, but it's also oxygen that's causing us to age. Well, that oxygen is causing us to age, it's causing oxidation. Well, ozone is even a higher level, faster level of oxidation. But what happens is that ozone being so destructive, it basically kills bacteria, viruses, spirochetes, mycoplasma. It kills everything, yeast. It's very, very detrimental. In fact, if a person inhales ozone, in our nursing staff, while they're doing the blood, if they actually get a whiff of that ozone, like 3 seconds, okay, 2-3 seconds worth of inhalation of ozone, they get a severe headache, and it can take an hour, half an hour to an hour for that headache to resolve, and they have to sit down, and it's not a pleasant experience at all. But why are we using it? Then we're using it because it's so antibacterial, and antiviral, and antispirochetes, et cetera, et cetera. When you put it into the blood, it kills basically everything that could cause an infection in the body. But wait a second, if it's so destructive and the person's breathing it can cause such a problem, then infusing in the blood, isn't that going to make them really sick? Couldn't that kill them? And the answer is no, because the ultimate engineer, God, created our systems in a certain way that we have what I refer to as a compensatory safety mechanisms. So in the live system, humans, animals, in the physiology of the mammals, I guess it's not in plants, I don't think, but it may be the same thing. Well, plants actually breathe out oxygen. They breathe in carbon dioxide and they breathe out oxygen. So it wouldn't be applicable to the plant kingdom. But in the animal kingdom, anything that's responsible or utilizes oxygen is utilizing oxygen for sustainability, for survival. We have some compensatory mechanisms in our blood. So in the red blood cell is what actually has the hemoglobin in it. Hemoglobin is the iron carrying capacity of the blood, okay? And it's dependent on iron. it's an oxygen binding capacity of blood. Excuse me, I said that wrong. It's dependent on iron, but hemoglobin is the oxygen carrying capacity of blood. So in red blood cells, and actually in all the animals, as far as I know, there are two things. There's actually a couple of them, but there's peroxidase and catalase. And these are enzymes that are designed to compensate for the increase in oxidative injury when exposed. So let me give you an example. Think of those movies, right? When somebody's in the tunnels underground, say in New York City. So they're walking through these tunnels, and there's sewage, and there's it's dirt, and there's rats, and just it's all infested with everything that's bad. But they're in these tunnels, and then in the movie there's like a bomb that's set off or some kind of fire, and you see this wall of fire coming, and the person's trying to run. You've seen those in the movies, right? They're trying to get out of the inferno as a wall of fire comes through this tunnel. Well, think of that. Think of those people in there as firemen, and they have these blankets, like fire retardant blankets, to protect themselves. So as that wall of fire comes through, it's going to kill everything. Any person that's in there, any rats in there, any alligators in there, whatever's in there, bacteria, whatever, it's going to kill everything. And it's going to, when it goes, it's going to leave everything dead. There's going to be nothing. It's all going to be sterilized because that wall of fire came through. But these firemen that are in there, they can crouch down and they can grab those fire retardant blankets and cover their bodies up. And that wall of fire blasts back through them, kills everything else, but it doesn't kill them because they've got the fire retardant blankets that protected them as a ball of fire went through that tunnel. Well, that's exactly, why am I telling you this? Because of a movie or something? Why am I giving you this visual analogy? Because that's
easier to understand.
Exactly, because that's exactly what's happening inside the blood, in the body, when you give ozone therapy, when you do ozone autohemotherapy. Auto meaning your own, and hemotherapy meaning blood. So you basically take out the blood, you ozonate it and put it back in the body. You're basically sending in a wall of fire through your blood system, and it's killing everything. It's killing every single bad pathogen, virus, bacteria, whatever. It doesn't make any difference what it is. Ebola, you can name it, whatever it is, COVID, whatever. It's going to kill everything. But why doesn't it kill the red blood cells? Because the red blood cells, why doesn't it kill all the cells in the body? It's actually, we're more concerned about the red blood cells. Why doesn't it kill everything else in the vasculature within the vessels? Because the body has the ability to compensate. The fire retardant blankets that we have are called catalase and peroxidase. So they come out, they increase rapidly to help the body to sustain it. It kills everything else, but the healthy cells don't get damaged at all. Now, what's interesting is cancer cells don't have the capability of increasing peroxidase or catalase. They can't produce it. Neither can bacteria or viruses or spirochetes or mycoplasma or yeast. They don't have the ability to produce catalase and peroxidase. And so, I had one person ask me, well, Dr. Buttar, can I just take catalase and peroxidase as a supplement? Will that help me? Unfortunately, no, because, these are enzymes, and when you take them orally, it's going to get denatured in your acid in your stomach anyway. It's not like that. It's a normal mechanism that is designed in our physiology. Is another one of the wonderful, miraculous things how the Creator designed our bodies. So that catalase and peroxidase is responsible for protecting us from that ozone. But ozonation is a tool that we can utilize in the clinic. It's, again, the same thing we're talking about. We know that ozone is highly oxidative. We know that. It's a known thing. But we're taking it and we're utilizing it inside the body in a manner that doesn't promote the oxidation, but decreases the burden of the system for things like bacteria, viruses, and spirochetes. But here's another thing that it actually does, and I'm so glad, Dr. Lyons, you're like the point guard in a basketball team. You threw the ball up there close to the hoop, and then you have me come in to slam it through the hoop, so I look like the so I appreciate the setup there. The other thing that ozone actually does that's so important is, in the German literature, it was shown about 50, 60 years ago that ozone was being utilized to break down chemicals, what we refer to as a persistent organic pollutants, the chemical toxicities. These are the fluorinated hydrocarbons, the benzenes, the toluenes, organophosphates, all these preservatives and insecticides and all these things that we know that are terrible. They're referred to collectively as persistent organic pollutants because when they get into the body, they persist. They can't get out. They can't be taken out. The liver cannot pull them out. So what they found was that actually ozone will go in there and they will break those persistent organic pollutants down to smaller subunits of whatever it is, that now the body can clear them, that the liver can actually clear it. So it takes a persistent organic pollutant and makes it not persistent anymore so that the body can eliminate it. And so this was studied in Germany, and this was actually published. Of course, here in the United States, they try to make a big deal that, you know, it's questionable, but Baylor and Mayo Clinic have been doing research with ozone therapy for, gosh, I don't know, at least 20 years. And I've been using ozone autohemotherapy in my clinic since 1996. So I've been using it for 24 years. As of next month, it'll be 25 years, so a quarter of a century I've been using ozone in my clinic. Ozone is a phenomenal tool. And again, it starts to show you, you know, you've got oxygen. We know we need oxygen in our bodies. Without oxygen, we're going to have a serious problems trying to survive more than 3 or 4 minutes. And yet it's the oxygen that's causing this oxidation to increase. And then another form of oxygen makes it even worse, that it makes the oxidative injury even worse, but yet it can be used as a tool to get an individual healthier in their current situation if they've got an infectious process or a chemical process or whatever the process is. And so it's really, you know, when you start looking at this diametrically opposed aspect that we have of good versus bad, right? It's all relative, because ozone is considered bad, yet in the right hands, when somebody knows how to use it the right way, it becomes an extremely effective, good tool. And oxygen, same thing. Oxygen is considered to be good, but actually, if utilized in the wrong manner, can lead to a lot of detriment. So this is one reason when people talk about the Second Amendment, they talk about the right to bear arms, and they talk about, you know, gun control, gun control, gun control. You know, if somebody thinks that gun control is important and we should take guns out, then I will tell you there's something far more important we have to do, and that is take spoons away from people, because spoons are leading to the obesity epidemic throughout the world. And of course, we know that's stupidity. So it's not the gun, or it's not the spoon. You know, a car is a mode of transportation. Very, very important to use a car. But here's the problem. You put a drunk behind that car, they can kill a lot more people than a gun would kill. So the point is, it's not the tool, but it's the idiot wielding the tool that we have to be careful about. So the current situation coming into COVID right now, you know, it's just nonsense. I think you and Dr. Lyons, I know how you feel, and I'm sure that most of your audience, the people that are more evolved and more intelligent, they kind of see that, okay, wait a second, all throughout our training, you know, virology, principles of infectious disease, human physiology, just physiology itself. I mean, even logical sequential thought process would show you that there's no such thing as, hey, wait a second, you know, you need to wear a mask, and if you're not wearing a mask, you're being irresponsible. That's like saying that, hey, you wear a seatbelt, so I'm protected. All right. How is you wearing a seatbelt going to protect you? Even if there was any basic fundamental advantage of wearing a mask, which we know that it is not. And I'm not going to go into all that diatribe, but the point is this: if anybody thinks that viruses are going, you know, the most deadliest virus on the planet supposedly is all of a sudden going to be protected by you just simply wearing a face mask that you can then take off as soon as you sit down in the restaurant, and then you can eat. But then when you get up, you have to put it back on so you walk out of the restaurant. I mean, this is political nonsense to a order of magnitude higher of stupidity than I've ever witnessed. And to see how the population the world's population has succumbed to this, it's.
I have to go back before you go far. I have to go back. I have another ball to the basket. Do you ever measured anybody in the 24 years of practice with ozone? Did you ever measure pulse pressure of oxygen on that patient changing, or maybe the saturation on the pulse oximeter? Did you ever see any changes of oxygen level somehow, somewhere? Did you ever check that?
So I actually haven't checked that consciously. It's actually something that we've been talking about doing recently. And I'll tell you, because checking partial pressure is not something that's typically done in clinical medicine. We use the pulse oximeters to check for oxygen saturation of the blood, but not for partial pressure within the tissue. It's not a readily available technology now.
Do you think it would change? Do you think it would change? It should change if I put O3 instead of O2?
Well, that's an interesting question. So with your help, you know, I've recently started doing this, checking the partial pressure of people, the tissue levels of the partial pressure of oxygen, the tissue levels of people. And here's what I think. I have noticed in a couple of cases where people had severe viral infections or bacterial infections, i.e. pneumonia, they had a pneumonitis, and they were measured with a pulse oximeter. And again, it's only measuring blood levels of in the oxygen saturation of blood, not of tissue. But what we saw that these people were, you know, say 92, 93%. And when we did ozone autohemotherapy, those individuals after the ozone therapy had a higher level of pulse oximetry. Their pulse oximeters showed a higher level of
saturation, higher
exactly,
saturation.
Exactly. But I think that was just because their lungs were able to, they were feeling better and they were able to ventilate better. There was less sputum or whatever that maybe it was that, you know, had them cough. And actually the pulse ox went from 94% to 96%. So there was a little slight change there. And it would be interesting to actually measure partial pressure of tissue and see what happens after ozone. But again, when you're using ozone, the thing with ozone is it's very, very transient. It lasts very, very short period of time. So when you actually ozonate the blood, it's not that, a lot of doctors, when they do this, they'll do 250 cc's of blood or 500 cc's of blood. But my mentor, who actually won a Nobel Peace Prize, he was part of a team in Mexico that won a Nobel Peace Prize for their work in in allergy and immunity. He actually explained this to me, and I learned how to do ozone with him. He passed away now, Dr. William Hitt. But one of the things that I didn't recognize, and that almost no doctor that does ozone therapy recognizes, it's not the volume of blood that you've ozonated. Sure, that volume of blood that you've ozonated will be clean. If you have 200 cc's or 500 cc's or whatever, then that volume of blood is clean. But when you put it into the body, remember, you've got, you know, 5 liters of blood in your body. So how is 200 cc's or 50 cc's or whatever, 500 cc's, how is that going to affect 5 liters? Well, when we do ozone, we're only using between 60 and 80 cc's of blood. So we use a lot less. And people said, oh, how can that be beneficial? We use 250 cc's, we use 500 cc's. It has nothing to do with how much blood you're ozonating. It's how fast you get that blood that's been ozonated into the body, because the ozone is dissipating rapidly. Within 5 minutes, that ozone is totally gone. It's already been utilized. So if you can actually ozonate that blood and get into the body, because what I'm interested in is creating that chain reaction, because as soon as that blood hits the body, it's causing a chain reaction throughout all the blood in the body. And that's what we want to do. We want to rapidly get that ozone in, so it causes this massive burst, and it's on quick and it's off quick. So it's not the volume of blood that you're ozonating that's important. It's how fast you get into the system. So by the reason I'm bringing that up is because your question, you know, how would we measure if use of ozonation would increase the partial pressure of tissue? I believe that the problem is going to be that there's going to be a transient nature of that ozone will prevent an individual to be able to, you know, see, for us to really measure. But again, ozone also ozone is not in a form that's being utilized by the body, which we typically would see, because we want to breathe in oxygen, we don't want to breathe in ozone. But we're using that ozone in a different way to get into the blood and use it as a sterilizing technique, as a method of breaking down compounds and chemicals. We're actually using the destructive nature of ozone for a purpose to destroy either chemicals so that the body can break them down, or destroy pathogens, opportunistic infections, so the body doesn't have to deal with them. We're not using ozone to actually increase utilizable oxygenation in the body. So I think that's an important component for people to understand. We're using the detrimental form of ozone, of oxygen, i.e. ozone, O3, in a manner that we would not conventionally want to expose the body. But here, we're using it in a way that's going to benefit the person.
Okay, so may I ask you for one day, maybe you tell your office to patient comes in, make a small measurement on pulse oximeter. And I know you have pulse pressure oxygen PO2 device too, to take these 2 stands before they start, and after ozone therapy, 4, 5, 6 ozone therapies, look at it again. Maybe there is some changes. The reason I'm asking you, because I know you are very big on also on hyperbaric chamber. I know you use hyperbaric chamber also. Yes. And I had the chance to work with the Hungarian Hyperbaric Chamber Association in Budapest, Hungary. And I had my own chambers too. And I was not reluctant to go inside the tube with the patient and start to measure constantly in motion oxygen pulse or pressure. And the outcome was just awesome, because for 1 hour, it was extremely high. It hit the roof. It was 2.5 bar pressure, and we were up to pretty long time, about 1 hour. And the pressure was contained 164.9 mercury millimeter constantly or above, because we could not measure more. Now we have a capability to see higher, but that time we could not see it.
I'm excited about seeing that, because yeah, when you see it hit that 164.9, you know that I don't know how it's going. Is it going to 170? Is it going to 180? And now that I know
it is, I'm telling you, I went into the hyperbaric chamber with the patient, and the sonda was on the patient completely. So that until we were in, it was constant. But as soon as the pressure started to decrease, drop down to 1.3 bar, and then go normal and go back to 0. So it was 152 mercury millimeter. Then the oxygen pulse or pressure in the tissue immediately start to decrease about normal level where we began with. That was a cancer patient, so it was very low. And
so you need 1.3. You're talking about 1.3 atmospheric pressures in the chamber?
Yes. But we bring them lower and lower and lower, and slowly we end up 0. You know, we end up 152 mercury millimeter, normal sea level condition. And as soon as the person step out of the chamber, soon as they step out, the oxygen pulse or pressure stopped. And this is other form. That's why I'm asking you, because this is all gas form of oxygen and pressure form of oxygen, approved by, I think, 13 diseases by FDA, Food and Drug Administration in the United States. But you know, what we saw if you get out of the chamber, the pressure already go away and no more oxygenation. So what we did, we put some special oxygen liquid into the hand of the patient when get out of the tank and drink it. And guess what? The pressure is not dropping down. It stays up to 80, 85 mercury millimeter for about another 45 minutes. And the patient is already out of the chamber. This is a very significant view of how we can keep it longer oxygenated. And you're absolutely right. There is a good balance. The body knows how to balance excess of oxygen, use it for killing pathogens. And the other part is to make the cells function, to give energy, produce different immunology factors, like, you know, you can have more antioxidant capacity of the body. So, you know, more oxygen, all of a sudden, if it's quick, it actually takes 1 picosecond to oxygenate, over oxygenate one person, but takes 9 seconds to respond. It's huge time difference between the two. When we saw this first time, we did understand why we can talk to immunology, why we can support epigenetics changes. Why? Because all these changes is going. So what I'm trying to get to you now is, I believe, and maybe you can share with me on this, I believe liquidized oxygen would be much more safer if the structure of the oxygen is right than all of the oxygen therapy what the Germans did for about 50 years, 60 years. They were in the right track, but I believe there's a better way.
I concur with you. In fact, you know, that's what brought us together, was actually the ability to use a liquid to carry that oxygen to the body and be able to have higher sustainable levels of oxygen in the system. And it's just fascinating. And, you know, you've been working on this for many years. I've been looking at water for many years, but I haven't looked at the potential of oxygen carrying capacity and effective utilization of that oxygen in the system physiologically. I hadn't looked at that till, you know, just a few years ago. And so it's been fascinating to see some of these things. And so I appreciate all your work that you've done in this technology, but it has great implications for mankind on a long-term scale. I think it's probably one of the most important changes one of the most important discoveries that's probably been made in the last 50 to 100 years.
Thank you so much. really thank you. And I also would like to thank you for all the support that you're showing us. And I talked to you many hours. I learned from you a lot. I try to give you information to have more better understanding of this way, because I believe humans can be helped without any extortion and any toxic medication. I believe we can help the people help naturally bounce back their homeostasis in their system. And you are one of my, not hero, I would say, one of my example. I'm looking at you, and I'm really truly appreciated. And my people here, they did not believe, first of all, you are coming. So thank you very much standing there. And
I appreciate your work, and your research has helped us a lot, developing what we've been developing. And it's interesting, the parallels of all the stuff that's out there, but you've been doing this a lot longer, and you've helped us tremendously with our ability to use liquid in a way that a person can increase their oxygenation. So we're really appreciative and for your research and your efforts that you put out in the 20 plus years. So it's really exciting. And I've been able to utilize some of the ideas that you had, and I'm really anxious now to be able to measure the partial pressure beyond 164.9.
Yes, you will.
It's amazing what's possible. I mean, we're talking about, just so the people understand what we're talking about here. And we have a version of a water too. Obviously, I'm biased on our version, but it's very, very similar. And we've been able to, Dr. Lyons has really helped us to take our water up. We've got some other components. It's interesting how these things came together. I won't get into all the details, but it's extremely interesting to see this. When you watch this, actually, when you're watching a patient's partial pressure of oxygen, and seeing and realizing, my God, the atmospheric partial pressure in the air of water, it's obviously going to vary based on the altitude and the humidity and all these other things when you're looking at partial pressure of oxygen in the atmosphere of what you're breathing in ambient air. But when you have the partial pressure of oxygen as measured in ambient air at 145 or 150 or 155, I think if you're close to the ocean and you're in a high humidity area, and it's if you're close to sea level, you're going to get about 154 millimeters of mercury in ambient air. And then when you can put it into a liquid medium, and you see that oxygen level increase, not decrease, then you start saying, wait a second, how is it possible that this water can have a higher level of oxygen than the oxygen that I'm breathing in air? And when I was able to measure that in our water, I was just shocked. I would have not known to be able to do that without your work. So anyway, I'm very appreciative of that.
Okay, I let you go now. Thank you very much. Thank you so much. And I catch up with you in Las Vegas. I hope you're coming there to see me, or I go to see you wherever you are. You find for yourself a follower. So thank you very much being here. Thank you so much.
Thank you. Thank you very much. Take care.
Thank you, Dr. Buttar. Thank you.